welcome to CDIQ Consulting CCDS Exam Prep monthly webinar series. This is actually part 2 of this month's webinar. We had part 1 last week, which talked more about test-taking strategies and other obstacles to think about overcoming, which can be quite easily overcome with some good discipline and practice for passing the CCDS exam. And today's second part, we go back to talking about a particular organ system, in this case, respiratory diseases. So we're going to look at a few different components here for today. And, let me just get my slides advanced. So a brief something about us, if you don't already know, I'm Dr. Tarman Aziz. I'm an internal medicine physician by training, and I have several years of experience dating back to around 2011, working in the CDI arena, as well as a physician advisor, CDI program director, and I'm also seasoned in revenue cycle consulting. I've also recently refined my process in composing appeal letters to help those second level appeals or DRG downgrade type of denials in particular, which I like to focus on. I operate CDIQ with our Chief Operating Officer, COO Anna Rusanowski, who drives all of our business growth, is our client champion, and works with our supporting team that you see on the right, focused on our business development, sales, marketing, and social media. It's a pleasure to bring these monthly and sometimes more than once in a month to help with the CDI community's understanding of that which needs to be mastered to be successful on the CCDS exam. So today we'll be looking at aligning provider documentation with accuracy for appropriate ICD-10 coding. Providers don't always know about how to do that. And then we'll talk about the exam itself in terms of which are the top 10 respiratory diseases that you should be familiar with when taking the CCDS exam. Finally, assessments. What are the troublesome or faulty provider assessments that drive the query process and also the chart review process in general? And that's best illustrated through some practice questions that we'll look at 5 or 6 practice questions in today's session as well and dissect those. Why are the right ones right? Why are the wrong answer choices wrong? And finally, a Q&A session. What are your questions for me about the topic, whether it's about respiratory diseases or anything else to do with the CCDS exam and how to prepare for it? So we'll go ahead and get started with talking about this first agenda item, aligning provider documentation with ICD-10 coding, which is a little bit tricky, as any of us that's been in the industry for any length of time knows that providers don't always write in a way that captures the correct codes. And that's where CDI comes into play, of course. So generally, providers don't always appreciate the significance of the coding guidelines and how their assessment and plan documentation ties into that final coding, final billing, but of course also final metric analysis across a host of different risk adjustment targets. And it's very important that we teach providers how to get the right type of documentation in place on their record. The trouble is that most of us, when we first endeavor to educate providers about CDI and about their documented assessments, we tend to do so using a heavy on the HIM vocabulary type of technique, and most of the education that you might inherit from colleagues and other department leads tend to be laden with this type of chart impact labeling for various diagnoses, such as comorbidity complication or CC diagnosis, major complication comorbidity or MCC diagnosis, and finally, hierarchical condition category or HCC diagnosis, which of course plays a very important role in outpatient risk adjustment, but also those HCC diagnoses are classically important for risk adjustment on the inpatient side as well. And so many of you that are familiar with CDI software know that the computer-assisted coding will tend to flag certain diagnoses as CCs, MCCs, HCCs, and so forth. That's great for us. That's great for our workflow in CDI, but it's not particularly helpful to enlighten a physician who may already be confused somewhat by the query process and what the questions are all about. So it means that our providers need a translation of the coding rules into a context that they can immediately appreciate, that they can understand. So you get that sustainable impact in the form of true documentation change. The culture of documentation has to change. So you might want to practice thinking today about how you would translate some of the coding rules that we'll visit that are specific to the respiratory system. All of this is testable information on the CCDS, the notion that providers are not particularly savvy in the first instance to HIM vocabulary. So as an example, we're going to start by talking about pneumonia. We can't possibly cover all the respiratory illnesses thoroughly in this session, but we can cover some of them. And certainly we know that pneumonia is one of the most important respiratory diagnoses. It's a high volume type of admission for pneumonia through an inpatient facility. And one of the things to focus on right away on the CCDS is remembering that certain documented assessments don't capture the right codes for what would end up being in a DRG for complex or complicated pneumonia. And they instead default to the simple pneumonia family of DRG. So we'd rather not be in DRG, MSDRGs 193 to 195 for the simple pneumonias, if in the end the principal diagnosis or PDX is actually one of the more complicated pneumonias that should take us to the DRG 177 to 179 group, which are officially known as the respiratory infections and inflammations. You can think of them as complex pneumonias if you don't already know that for those DRGs. So quite particularly, providers think they're giving us a lot of good information when they write things like community-acquired pneumonia, hospital-acquired, healthcare-acquired, atypical, bacterial. And in fact, most of those descriptors are of no particular value because in the end, they code to what type of pneumonia. Do either of you on the call know which type of code you would select if a provider writes any of these?
Just simple pneumonia?
You would be in the simple pneumonia DRG for sure, but what would be the actual code selected if a provider writes hospital acquired or community acquired pneumonia, or worse yet, all you get is CAP or HAP, some sort of acronym? The word I'm looking for here, rather than simple, to clarify, is the word unspecified. These goes
Okay.
to J18.9, which is unspecified pneumonia, because you've not specified an organism. And to make it into the complicated, complex, or respiratory infection and inflammation DRG group, which carries higher relative weight because these are more resource intensive pneumonias, then you must clarify what type of pneumonia is being treated. And for most of the time, that means naming the organism with suspected, probable, or likely, or consistent with type of language if it's uncertain. But as soon as you use the terms listed here, we have simply unspecified pneumonia, which groups to simple pneumonia. So that's a problem, and it's a hard one for providers to overcome because, of course, they're thinking clinically, and they feel they're giving you quite a bit of value in telling you this was an atypical mycoplasma pneumonia or similar with a less clinical severity than some of the others, but in fact, they all go to unspecified. The other part of aligning the documentation for ICD-10 expectations is to think about cultures and laboratory data and clinical suspicion. So first of all, when we think about cultures, remember that empiric therapy is quite common. giving large volumes of large doses, 1 to 2 grams of antibiotic right away based on the clinical symptomatology. And the problem is, of course, it can make any sputum, blood, urine, CSF culture, what have you, that might be drawn afterwards as falsely negative over time. So the point is we cannot count on a positive culture result in order to decide what type of organism we're dealing with. It may be up to the provider to let us know based on their clinical suspicion, as we see at the bottom of the slide. Also, even if the culture is positive, it's not enough to simply write any old pneumonia down as a provider and expect the coding team or the CDI team to come in and understand, well, the cultures grew this substance out, and it looks to be sensitive to these agents. And so therefore, we can probably make a conclusion this is gram-negative pneumonia or MRSA pneumonia or whatever. You need the provider to read those culture results themselves if they do happen to be clinically valid and positive, and then explicitly link that finding with a specific type of pneumonia. Otherwise, we're still not able to code it. So the sputum and blood cultures may or may not be there to help us. We also know that with pneumonia, it's not always the case that the white blood cell count is sky high. As pneumonia proceeds, especially if it's a more serious type of pneumonia, sometimes the white blood cell count comes back into normal range, but it's really on its way down to being a low value. And so the white blood cell count can be unpredictably low, normal, or high in the setting of pneumonia. And it's simply one more corroborating finding rather than something we can hang our hat on to say, for sure, we have this or that type of pneumonia. Same goes for X-ray findings. If a patient is severely dehydrated, for example, the chest X-ray may not reveal any infiltrates until a little bit more adequate hydration is in place. And we also know that for, in general, then counts, cultures, X-ray findings, imaging findings, they're helpful for clinical validation once you know the type of pneumonia. The type of pneumonia must be explicitly documented by providers, and they can do so by just indicating their clinical suspicion. Oftentimes, they do it via the antibiotic that they select. So another high-yield testable concept on the CCDS exam, the notion that you can use orders for perhaps a more sophisticated third or fourth generation penicillin to imply that the provider is probably treating something more serious in nature than one of the regulation issue commonplace organisms that causes simple pneumonias. And you can simply ask by way of provider query, we see you've documented pneumonia. We see you're using XYZ antibiotic. Can you please further specify, using your independent medical judgment, what type of pneumonia you may be treating, including, and you have to include, of course, unknown, unable to determine. But you may include in there some of the more obvious potential causes of pneumonia, along with some of the more exotic organisms that can cause pneumonia, and see which one the provider might gravitate towards. So know the compliant query process for pneumonia and specifying the type of pneumonia when it comes time for the CCDS exam. You can see that that specificity again impacts DRG assignments whenever pneumonia is the PDX. We also know anyone who's got experience in CDI knows that typically they are MCCs when they are secondary diagnoses. Pneumonia, even unspecified pneumonia, is an MCC. However, to get the right payment and the right risk adjustment when pneumonia is the PDX, it really matters to entertain this idea, particularly based on the treatment of choice. What is the most likely pathogen being treated? So we can get it right and we can get into the right DRG straight away. So you can see at the bottom, for example, I've clarified the difference between a gram-negative pneumonia and a simple pneumonia in terms of DRG assignment when those pneumonias are the PDX. You can see the relative weight potentially is a lot higher if you have the with MCC or even at the level of CC or neither CC nor MCC. Uh, you have a higher rate of payments. You have a little bit longer length of stay as well allowed for with gram-negative pneumonia. Of course, that's not the only complex pneumonia, but it's a very commonly invoked query. Are you treating gram-negative pneumonia based on the antibiotic that you've selected? So that's a source of many questions. You might ask yourself then out of that discussion, I hope you would be asking yourselves out of that discussion then, what are the other types besides gram-negative pneumonia that when they are the PDX, they align with this complicated or complex pneumonia? There would be way too much for me to describe on a simple slide. So instead, I provided you with a website that I can probably copy here and throw into the, maybe not in the show version, but in any case, yes, let's see here. I can open this up and bring it over for us to look at. Bear with me while I get this onto the screen. So now I've taken us from the presentation link to the cms.gov website for DRG assessments. And you can simply dial up DRGs 177 to 179. You see them here. Respiratory infections and inflammations, either with MCC, with CC, or without CC-MCC. And it doesn't much matter which of these three you look at because we're looking for the PDX list that gets us into this category. So what we can see here is if any of these influenza codes serve as the PDX or influenza codes where there's an associated pneumonia of some type, we end up in this family of DRGs. So what is that secondary diagnosis? What are those pneumonias that typically bring us when they coexist with influenza? You can see them here: Legionnaires, Klebsiella, Pseudomonas, staph, whether unspecified staph or MRSA, either one, or even methicillin sensitive. Also E. coli, Acinetobacter, gram-negative, and other specified bacteria, of which there are many. So this combination can get you into the group that is DRG 177, 179, higher resource intensity, greater length of stay. Or you might have any of those as your PDX, those pneumonias that were just listed as going with influenza. And you can see the list is quite long. I'll let you go through and look at it in your own time. Some of them are more rare conditions, such as those seen in the immunosuppressed population, fungal pneumonias, cytomegaloviral pneumonias. But eventually you get down to some that you see more commonly in CDI chart review, like Klebsiella, Pseudomonas. Again, these were the secondaries with that influenza category, but all by themselves, these pneumonias, when they're the PDX, group to the more advanced or complicated DRG grouping. So keep them in mind. I would say from J150 down to the pneumonitis, the aspiration J690. These are all fair game for CCDS that you should know these default out to the complex respiratory infection and inflammation DRG. All right, so that's probably enough on that. But please do go to this link as we just did and take a look in your own time. Okay, so the specificity impacts DRG assignment when pneumonia is the PDX. Even when it's not, the more specific we can be, the better the impact to metrics. So here, for example, we see almost, it's not really true. The general rule is that pneumonia is always an MCC, but there's going to be an exception to any rule. You can see here, hypostatic pneumonia, J18.2, is in fact a CC for those patients that are recumbent and not moving much. But In general, pneumonias are MCCs. And you can see that still it would be worth specifying some of them. For example, that J150 to J1529, these all group to HCC 282, as do some of these down here. The aspiration and specified bacterial pneumonias are a part of the HCC system. And as mentioned on the initial slide about pneumonia here, here's J18.9, pneumonia unspecified, the least desirable code for CDI specialists and coders to use. We'll use it if we have to. But unfortunately, all these community acquired and healthcare associated and hospital associated, they all default to this J189, and rarely does that capture the best PDX. We're really looking for more specificity, again, not only for reimbursement, but also for risk adjustment. And of course, there are other diagnoses that we should be cognizant of when we think about respiratory diseases and the provider assessments that may be asked about for CCDS knowledge base. So atelectasis is another highly tested area for CCDS. And how does this work? Well, most of us in CDI know that atelectasis is a common finding. If you read 15 chest x-rays, 20 chest x-ray reports in a day as part of your workflow in CDI, you know that many of them, a large percentage of them, if there's pneumonia or anything else brewing, heavy amount of pulmonary edema, you might see atelectasis present. And normally we don't bother to code it unless what? Unless it is clinically significant, meaning typically it's a more persistent or large area of atelectasis that requires a little bit more input from the treatment team than the standard of care, where you're simply just following a simple post-surgical protocol or maybe using an antibiotic to clean up an infection. And with that clearing of the infection comes resolution of the atelectasis. You wouldn't bother with those transient examples. But if you see a little bit more treatment effort being made, perhaps a stent is placed, even to improve aeration due to large, widespread atelectasis, then it's worth considering and documenting because it is a CC complication comorbidity diagnosis for many cases when it is clinically significant. How would we know it's clinically significant? Well, CDI specialists and coders are very astute at teasing out the details from the medical record, but we're not able to make that conclusion alone. We can't simply look at a radiology report and say, that's good enough. The radiologist is a physician. They've said it's significant atelectasis. We need the provider for the admission. Radiologist is not technically a provider, even though they're a physician. So you need one of the admitting providers or consulting providers to point out the clinical significance of the atelectasis in their assessment and plan to bother picking up that CC diagnosis. All testable information for CCDS. So you might consider practicing, as I mentioned earlier, how to give this type of information in a non-HIM, non-HIM acronym type of way to providers. And one way you might summarize the value of atelectasis to providers is shown in this subtitle. Atelectasis impacts the severity as well as risk adjustment for a case when it's treated beyond the standard of care. So if you give that to providers, they can easily understand we did more for this persistent, larger area of atelectasis. And as such, we should probably mention what we did for it and why we needed to do it. So if there's evidence of worsening dyspnea and poor oxygenation, link it to the atelectasis. That's what providers need to be doing. Whether it's through query or through education that they achieve that depends on the program and depends on the provider. Of course, we may see a careful attention to chest x-rays with serial chest x-rays and CAT scans being used for closer monitoring. And if the clinical care requirements do extend to something more invasive, like a stent in the bronchus, for example, one of the branches, then you know you're dealing with clinically significant atelectasis. If the prognosis is worse because of poor ventilation, for example, that also can help us. So really important not to rely on radiological findings and instead look for those providers to be putting in a more valiant effort than that. A lot of the work in CDI for the pulmonary system respiratory diagnoses, of course, revolves around respiratory failure. And for respiratory failure, you can see that the subtitle, which again is meant to be a summary of that which we might share as a providers, which is also how you're meant to think about it for the CCDS, for some of the questions, you can see the advice is a bit more than mention when it's significant so we can code it. Instead, we have a lot of instructions to providers. Can you tell us if it was present on admission or not? As CDI specialists know this. If you've reviewed charts for a few years like you're meant to before taking CCDS, then you already know that many times acute hypoxemic respiratory failure either sticks around too long after it already was resolved in the ED and should never have even been on the history and physical, or it may be a situation where it doesn't appear on the record until day two progress notes. And oftentimes, the day two progress note appearance of acute hypoxemic respiratory failure is problematic because the condition was actually present on admission and just not documented properly on the HMP. So both can happen. It might be there inappropriately at admission as a leftover of ED documentation that should have been removed, or respiratory failure might be truly POA and missed until later progress notes. Either way, the first piece of advice is critical. Confirm the POA status. Then acuity comes next. Acute respiratory failure is an MCC. Chronic respiratory failure is a CC. And to be as specific as you can, if it's truly acute on chronic respiratory failure, that too should be mentioned. Unlike the heart failure story that we talked about last month, where you need both acuity and type to get MCC status, any type of acute respiratory failure documentation will get us an MCC, but it's nice to get hypoxemic, hypercapnic, or both out of providers because that may make a difference to expected mortality. It may make a difference to risk adjusted length of stay or readmission risk. And so we do want to know the type of respiratory failure for other reasons besides just grabbing an MCC on the record, which should never be the driver for anything. We want to specify with good purpose. And finally, if respiratory failure serves as one of several SOFA criteria or simply evidence of severe sepsis using the older definition, the SIRS-2 or the sepsis-2 SIRS-based definition, mention that link. If you feel that acute respiratory failure came as part of evidence of organ failure for sepsis, as a provider, you should write that down in the assessment. Providers rarely link organ failure properly to sepsis, despite repeated education from CDI, from coding, from their clinical leaders, even from C-suite executives. So those types of pervasive problems with documentation are likely to be testable material. It makes sense that to get certified as a CCDS approved CDI specialist, you already understand these common themes from being in the industry for a little while. So none of this should be a surprise to anyone that's been working in the industry a little while. So another piece that gets very confusing is defining acute respiratory failure. Hospitals are very busy writing interesting policies about clinically validating acute respiratory failure with particular flow rates for oxygen supplementation or with other elements to do with how long a person has been ventilated. But really, none of that's necessary. In fact, ventilation is not a mandate of making this diagnosis. The definition is simply impaired respiratory effort, typically features some increased work of breathing, as well as objective evidence of, for the second part, hypoxia, hypercapnia, or both. So if you see increased work of breathing, evidence of hypoxia, hypercapnia, or both, it doesn't much matter what oxygen therapy is on board. You may well be dealing with acute respiratory failure that needs to be defined as such. And most importantly, we don't want providers to use these less than ideal descriptors below. None of these severe dyspnea, apnea, hypoxia, labored respirations, respiratory distress. We know these last two, respiratory distress and respiratory insufficiency, commonly appear on provider records, yet they don't align with the ICD-10 code for any kind of acute respiratory failure. So if that's what providers meant to convey, they didn't do so with any of the entries on the bullet pointed list below. Also, PF ratios are commonly talked about on the CCDS exam, and you should know that a value less than 300 suggests acute hypoxemic respiratory failure. In the right setting, if there are risk factors for ARDS, acute respiratory distress syndrome, which is actually a subtype of acute hypoxemic respiratory failure, you might see PF ratios down in the 200, 150, or even 100 range. So the lower the number in the setting of the right risk factors could indicate ARDS, quite specifically, not just the more general heading acute hypoxemic respiratory failure. You're also tested to see if you know that other afterthought here in the first bullet point, but it's an important one, that if you have a patient on oxygen supplementation at home chronically for a chronic case of hypoxemic respiratory failure, the PF ratio is no longer accurate and not reliable as an indicator of failure. So keep that in mind for questions as well. Furthermore, airway protection is not a good description of any kind of true acute hypoxemic respiratory failure. If you're educating with a provider verbally on this topic, you might simply ask the patient, you may ask the provider if the patient has the endotracheal tube removed, could they breathe or not breathe using their own respiratory effort? And if the answer is no, the patient wouldn't be able to breathe if I were to remove the endotracheal tube right now, then they're already in acute respiratory failure, most likely. And there's no reason to call it airway protection anymore. Airway protection would be for anticipated imminent failure that hasn't actually happened yet. Again, a testable concept. So too is the idea that post-procedural or post-op respiratory failure is an important patient safety metric, triggers a patient safety indicator if it's truly there after a procedure and it could have been avoided. Mechanical ventilation beyond 48 hours post-op, when you need the ventilator longer than 48 hours, it can be the sign of a post-op or post-procedural respiratory failure. But again, providers don't always give us the best documentation, whether it's because they don't know what to write or they prefer not to implicate their procedure and have it associated with the experience of acute respiratory failure subsequently. Doesn't much matter what the speculation is on why. The goal is to get the right documentation in place. So we have a host of different things here to consider with respiratory failure in general. And again, the last point is essential. People on 4 to 5 liters of oxygen by nasal cannula, high flow, BiPAP, those are all common respiratory interventions when a person has acute respiratory failure. They don't need to be mechanically ventilated in order to have that condition. And it's tested in a few different ways on the CCDS. That concept is tested. So it brings us to the question now about exam day. I've given you a little bit of a dive into some of the nuances and details of a few respiratory diseases there. But of course, that's not the extent of the respiratory diseases that you'll meet on the CCDS exam when you finally sit in a testing center like this one and take the exam, or if you take it uh, through your own uh, machine, which you certainly can do as well. So look into your local testing options. But ultimately, for the respiratory system, we need to think about these conditions. Pneumonia, acute respiratory failure, we've already talked about. Chronic obstructive pulmonary diseases. Remember that COPD is an important risk adjustment for the outpatient setting, and varying degrees of impairment from COPD chronically will affect that outpatient risk adjustment factor for scoring and ultimately for outpatient reimbursement. But remember, in the hospitalized setting, many times COPD presents with infection or in an acute exacerbation state or both. And COPD with infection or acute exacerbation uh, earns a CC, not just an HCC status. So impactful, you have to know specifically that acute exacerbation and infection in the setting of COPD is important to link, and it's important for providers to clarify for that CC impact. The next listed is asthma. Asthma is sometimes tested. It's not tested as heavily as the other topics within the lung. It's important if you know the asthma is mild, moderate, or severe, as well as if the symptomatology is intermittent in nature or persistent in nature. Those are the most common ways that we're expected to specify asthma. Pulmonary embolism, technically it's a disorder of the circulation, but because it involves the lungs and the blood vessels of the lungs, it can also be considered a respiratory condition of sorts. And so it makes the list just because of its association with that particular set of blood vessels. And we talked about PE last time and the value of having acute versus chronic explicitly stated in documentation, as well as if there's any associated heart strain and or cor pulmonale, where you essentially have acute right-sided failure in some cases. That's common with large saddle emboli or other larger territory pulmonary emboli. ARDS, acute respiratory distress syndrome, you should know the circumstances that can lead to ARDS, and keep in mind this is in common what the causes have is non-cardiogenic causes of pulmonary edema. So this is not pulmonary edema from heart failure and the lack of proper forward momentum of blood flow, but rather something that's not cardiogenic, triggering pulmonary edema, and usually occurs in all four quadrants of the chest X-ray. So you can see that snowstorm type of picture on the X-ray findings. ARDS should not be coded with acute hypoxemic respiratory failure. It is an additional level of specificity. So just like you wouldn't code acute tubular necrosis along with acute kidney injury unspecified, you don't have AKI unspecified anymore if you have ATN. You also don't have the generic heading acute hypoxemic respiratory failure anymore if the patient truly has acute respiratory distress syndrome that has its own code to describe it. Also tested on CCDS. Atelectasis we mentioned. Pleural effusions are much the same as atelectasis, meaning that we wouldn't bother to code them away from the condition that causes the effusion unless they were significant in nature and required additional intervention. So pleural effusions are typically intrinsic to heart failure exacerbation, acute CHF flares, but you might see in the setting of, for example, pulmonary neoplasm or metastatic cancer to the lung, whichever the case may be, that you could see notable effusions that required additional effort and justified separate coding for the effusion. Otherwise, if it's just in the setting of acute CHF, and as you resolve the edema, the effusion goes away, then you wouldn't bother to code it separately. Same goes for pulmonary edema in general. There are codes, of course, for pulmonary edema, but we don't need to use them when that edema is obvious and intrinsic to another etiology that's already being coded, unless it was edema above and beyond requiring care above and beyond standard. And finally, pneumothorax. It's important that you can differentiate a spontaneous pneumothorax from a tension pneumothorax that may compress the mediastinum and the opposite side lung. And think about typical scenarios. For tension pneumothorax, for example, having a rib that's broken in two places and creates a one-way valve that can trap air in with each inspiration, but does not let air back out with expiration is a common theme for identifying a tension versus spontaneous pneumothorax. Keep in mind, some of the CCDS questions are about medical knowledge. They're not all about applying coding rules and knowing about ICD-10 theory or about query practice. Some of it just is about your medical knowledge as well. So make sure you understand the basic anatomy, pathophysiology, and treatments in the way of pharmacotherapy for these 10 conditions as well. Well worth reviewing this list. So that brings us in the time remaining to think about some of these assessments that are faulty in some way or have some been embedded in some sort of short clinical case on the exam. Typically, they ask you about what type of query to send, or should you send a query at all? And if so, why? Those are the types of themes that can come up in multiple choice questions. So here's where I'd like to turn it over to the both of you for some practice in that regard. Let's take a look at the first practice question together. And I won't read it out loud. I'll give you a chance to read. And if you want to use the chat box, feel free to do so. Otherwise, welcome you taking on the microphone and sharing verbally what it is that you think the answer is and why. So take a few minutes to do that if you would. Okay, on the exam, you'll have probably about 60 to 70 seconds, a little over a minute maybe, for each question in the first instance. You want to spend not much more than that, maybe 75 seconds maximum, so that you have enough time after you complete all of the items to go back to the top of the exam and double check all your work, maybe address the items that you've skipped. And those that you flagged as you're not quite sure about your answer, you want to go ahead and wrestle over those choices maybe one more time or even two more times before you hit submit on your exam. So I don't know if I gave you a full minute or so, but do either of you have a thought on the answer for this question?
I probably would choose B.
Very good. Thank you for that. And B is the correct answer. Can you tell us how you came to that choice based on the item and the details in this question?
Based on his history, he's a smoker. Recently, he was hospitalized with an exacerbation. He had an infection when he first came in. He's being treated with empiric antibiotic, and he has a fever. The chest X-ray stated that he had pneumonia.
Very good. And so, with all that said, what is the problem with this documentation that prompts choice B as the best answer? I agree with all that you've said so far.
He documented, like you said earlier, that's an unspecified pneumonia where he could be very, what's the term I'm looking for? Specific about the type of pneumonia, which I would probably say it's a gram-negative pneumonia
Yeah, it does
based, based,
seem like it could be, right?
based on their documentation.
What else could it be that also makes it onto that list of uh, pneumonia PDX that goes to the more complicated DRG? Look at the second line in the documentation. We
It
we've
could be aspiration also with the sputum and the dyspnea. Yeah, it could be aspiration.
It could be, or it could just be an anaerobic organism. Uh, it says here that the patient has a history of anaerobic lung infections. So
Okay.
maybe this provider thought they were telling us, I have a suspected, probable, likely anaerobic pneumonia here, which would get us to that list that counts for the right DRG for this type of case. But they're certainly not saying it explicitly when they say history of. And
Okay.
many think that history of is good enough. But of course, we want to know that this current admission features not any old hospital acquired pneumonia, but in particular, a hospital acquired anaerobe is the driver of this infection. So, very good job getting to choice B here. The others, clinical validity query you would send when you're not sure about the diagnosis at all. It sure looks like there's some pneumonia on board from the story. So, clinical validation, not at the top of our list. Sepsis criteria query based on SIRS findings. Well, we had a fever. I didn't see any evidence of tachycardia mentioned. I don't see hypotension. I don't see tachypnea. I see dyspnea, but not tachypnea per se. So we don't really have a good, strong indication from the author of the question that we're thinking sepsis here. It looks more like pneumonia, lung infection, rather than true systemic involvement. And querying for documentation consistency across the patient record. There are times we might send conflicting documentation queries, but we don't have anything particularly at conflict here. It's simply that the language hospital acquired pneumonia codes to unspecified, as you nicely described, and that doesn't work here for this question. Let's have a look at the next one together. A little bit shorter, give you a little time to process this one. Now remember on the CCDS exam, you'll sometimes get a question correct because you know the answer, and other times you may get the question correct because of elimination of a couple of really bad choices and then contemplating two reasonable choices and deciding which one is the best. So a question like this, you can quickly eliminate a couple of choices, and two would be reasonable to consider. And then you can read deeper to know which one it is. Any input on this question from those in attendance?
Are you asking which one would we eliminate?
Either that, or if you already feel that you know the answer, you're certainly welcome to share it. But it's always good to simulate the question analysis process as well as we go through. So post-operative respiratory insufficiency, does that documentation and the assessment and plan match the clinical scenario particularly well? If you think it does, and D, no query required, we're good to go, with that documentation will be your choice. So yes or no to choice D, what do you say?
I say no to choice D.
Good. I say no to choice D as well. And why is that? What doesn't
Not,
ring true? What doesn't ring true here that makes D wrong?
mm, I don't think it's best aligned with the ICD code. I don't think it's the best answer. I'm
It's
not sure.
yeah, it's not the best. What do we see about this patient? We see an increasing level of dyspnea and hypoxemia, which we said when someone has increasingly worse dyspnea and hypoxemia, we can think about acute respiratory failure rather than insufficiency. So the word
Correct.
insufficiency doesn't look too hot for this scenario, particularly when the patient required urgent ICU admission, presumably for closer lung monitoring and even ventilatory support, perhaps.
So
So we,
perhaps A for the answer.
so yeah, I would argue as well that C doesn't work. Comorbidity unrelated to surgery. We're told here this is happening after a surgery, so why jump to that? So it's either
Hmm.
going to be A or B. We're either looking to query for post-op respiratory failure, acute hypoxemic, either because it's a complication related to surgery or as an expected clinical outcome.
I'll probably eliminate expected clinical outcome because the patient no have no prior history of any respiratory issues, like it says.
Very nicely done. And that's exactly why the answer is A. In this case, you nicely picked up on the fact that the person in the question, the patient, the fictional patient, has no prior pulmonary conditions. So why on earth will we expect the patient to experience post-op respiratory failure? Had we been told heavy COPD history with multiple exacerbations requiring admission, something to drive home the point that perhaps they may just have post-operative respiratory failure as an expectation rather than a complication, then we would pick choice B. So very nicely analyzed there. Good job.
Thank you.
You're welcome. Let's have a look at number 3. For this next question, you would have to know the ICD-10-CM guidelines, and you would need to know that acute primary respiratory acidosis, as quoted in the documentation, aligns with one of these four diagnoses listed.
I'd probably pick B, and I believe, yeah, the respiratory acidosis is not the same as acute respiratory failure. It would code as that also.
It would code as it, but it would be hypercapnic rather than hypoxemic. Even though
Uh,
there's hypoxia clearly present, uh, the equivalency between acute primary respiratory acidosis is acute hypercapnic respiratory failure. So you're close,
okay.
um, even though clearly there's some hypoxemic ongoing as well.
But
So
what
this,
about the COPD?
yeah, you would also go ahead and code the
Wouldn't
acute.
it be acute and chronic? That's where I pull the acute and chronic from because of their
Sure.
COPD.
But remember, COPD, not every patient with COPD has chronic respiratory failure. So COPD patient, um, it doesn't say that the person is dependent on home O2.
Oh, okay.
And it doesn't say that they suffer with hypoxemia to a certain point without that consistent home O2. So we have COPD for sure, likely an acute exacerbation as suggested, but we also have an acute hypercapnic respiratory failure. We probably have acute hypercapnic and hypoxemic
Oh,
respiratory failure, but you'll notice we don't see that answer here. So you have to pick the best available answer on the CCDS. And
okay.
that's the only thing that makes choice B wrong is there's no tangible evidence in the question of chronic failure. So you're looking for just an acute form that matches the statement about acute primary form of respiratory acidosis, which the coding guidelines allow for. Coding choice C. Good. Okay, we're coming up close to time. I can stay on for a few more minutes if you can. Otherwise, we can conclude the session. What do you prefer? Happy to stay on a few more minutes if you are.
I was waiting for the other person to
Oh,
respond.
a few more minutes is fine with me.
All right, then. I only have a few more questions for us. Why don't you go ahead and we'll go through these a little faster. Maybe I'll just read through them instead of pausing. So here we have a 65-year-old, fever, dyspnea, and on hospital day 2 is now being treated with the fourth generation penicillin, which replaces an initial choice of ceftriaxone that was given in the ED through to the end of hospital day 1. Cultures and all that are negative, and we see the initial admitting team documentation as well as ongoing notes. Pneumonia, continue current antibiotic regimen, ID consulted. So we want to know to ensure the right coding, what type of query would be most likely send. And this is really just a repeat of the earlier question given to you a little differently. We need to know the type of pneumonia. So again, we don't question the clinical validation, clarification of clinical findings queries. We, of course, use those to establish a diagnosis potentially that is supported by risk factors, clinical indicators, and treatments, but is yet to be diagnosed. And since we have pneumonia already on the record, no need to ask if some of the findings line up with pneumonia. That's not where we are. We're looking for the type of pneumonia. And many people pick choice D. No CDI query is compliant until the ID consultant gives their input. There's no need to wait on the infectious disease input to query for the type of pneumonia when you see a change in the class of antibiotic from ceftriaxone to zosyn in this case. So you wouldn't need to wait on that individual, even though their input as a consultant may help. Next, we have a question about more to do with compliance and asking a query question compliantly, you should read the CCDS guidelines as published by AHIMA on effective and compliant query practice. The examinee handbook also lets you know to read that document, about 20 or 25 pages or so to get through. Gives you real gems for the exam on how to write effective queries. Here we see a case of acute hypoxemic respiratory failure, extensive bilateral infiltrates. Provider mentions in the documentation anaerobic versus gram-negative versus mixed type of pneumonia with ARDS. There's no mention of PF ratios, vent settings, or anything like that. So we want to compliantly ask about ARDS. Is there one of these that looks more compliant than the others? And if so, why is that? And a hint for you on this question is that CDI specialists do not question the clinical acumen of the provider. We only ask for clarification on documentation. So if something sounds like we're questioning clinical judgment decisions and management decisions, we probably don't have the right answer. Excuse me. So could you please clarify if PF ratios are monitored to assess the ARDS severity? That's a clinical management question. You're not going to ask it. Or would you please document the vent settings that support ARDS severity? You're questioning if the ventilator settings would match the assessment, so that doesn't work either. The way that we generally ask clinical validation questions is simply to ask for more indicators. If you look at choice D also, is there any additional information that may be offered? It's a bit vague, but could you please provide additional ARDS indicators is always a safe way to ask the clinical validation question. You might do the same thing for sepsis. You might see no real evidence of sepsis, yet it's all over the record. You would simply ask for additional evidence, additional clinical indicators. It's the most neutral and the least leading and therefore the most compliant way of the four choices. Finally, we have a true and false question here. In the case of a massive acute PE, patients placed on heparin drip, and we see the following documentation. Acute saddle pulmonary embolism remains intubated in the ICU on pressors for refractory hypotension and shock to keep MAPs greater than 65. ICU monitoring reveals evidence of severe and acute right heart strain. And the true or false question here to end for the session, does this bias acute PE with acute cor pulmonale and cardiogenic shock? True, false, or inadequate info to decide based on that nice long provider documentation. Example, what do you think for this one? True, false, or can't determine if there's acute cor pulmonale and cardiogenic shock based on this documentation. How else can you ask yourself this question if you're not immediately sure? You might ask yourself, is severe acute right heart strain synonymous with or equivalent to acute cor pulmonale? And the answer is no, it is not. So that's a false statement. No more than saying shock requiring pressors to keep the mean pressures above a certain number. That all that gets you is unspecified shock. It's sort of likely to be either obstructive or cardiogenic in nature, depending on the circumstances because of the PE story here. But unless a provider explicitly states acute cor pulmonale or specifically names a type of shock, in this case, the question asks about cardiogenic, you can't assume it. As impressive as the documentation is, and as much as it goes on about different things happening with the patient, it fails to explicitly define acute cor pulmonale or cardiogenic shock. So you simply can't code those. You'd need to query. So that brings us to the end of our time. We do have another uh, free webinar next week on the 29th, but that one is for our comprehensive CDI apprenticeship webinar series where we train new CDI specialists through our different programs. And so we're going to be focusing on renal diseases for chart review techniques next week in that series. We're proud to be launching a new webinar series related to our upcoming May 5 release of a CDIP exam prep course. So on the 6th, we'll have applying CM and PCS guidelines for that. And then May 20th, so next month for this particular webinar series, we'll be looking again at provider assessments and talking about neurological diseases. If you have any interest at all in our programs, all of the information that you see here on this slide also available at www.cdiqconsulting.com, which is our website, and you can go through and compare the different options and what you get in each of the courses. Happy to share that with you in greater detail anytime by way of a one-on-one Zoom call. So that's all from my side this evening. Can I answer any questions from either of you before we sign off for the evening?
You say a separate explanation. I was interested in the number one with the 100 practice questions
Uh-huh.
that you have there. So yeah, exactly, the first one. So you
Yeah.
said I can just email or do a separate to go through this one to get more details on it?
Yeah, you can certainly go to our website and it's listed there. I can just quickly show you, uh,
Okay.
and it would probably be easier than. So I'll just take you to our website here quickly and bring it on over.
And these 100 questions are not the same as those you got from that when you purchase the book. Are they
That is
different?
right. That's correct.
Okay.
We have a distinct for our CCDS exam prep. If you are interested, you can see here mock exam. You would
Okay.
simply click on enroll now,
Hmm.
and it takes you to the place to purchase the exam. And upon purchasing, and you don't have to purchase it in one go. You have different payment plan options as well.
Oh.
Our team is an alerted. So yeah,
Hmm.
any of our products you can spread the costs out. Some of them are interest free. This one you
Hmm.
can, for example, divide it into 4 interest-free payments of $50, or you can even stretch it out further to 6 to 12 month payments. But the idea is you can go to our website and look at any of our programs, including the CDI training programs as well. And we're happy to work with you. And you would get enrollment information at that time. This one is 100 questions distinct from anything that is published in the ACDIS
Okay.
exam. And it also includes a follow-up one-on-one live online meeting with me to go over all of the questions that you did not get correct, as well as some of the ones that you did answer correctly that we've learned through time. Sometimes people get them right, but for the wrong reasons, or may need a little bit more tutorial there as well. So happy to work with anybody who's interested in those products. Thank you for asking.
Thank you.